Hi guys, I'm Galena. I'm going to talk about frostbite today for my wilderness medicine lecture. So going to start out with the case. This is actually um, based on a very true story in CCT, happened a couple weeks ago. So we have a 45-year-old male, past medical history. All we know is like ETOH abuse. He's coming in with bilateral foot pain, swelling, times many days. He can't really tell you how many, but notice blisters today. Um, Pain is like pin pricking, burning. When you get more history, the patient's been living in his truck. This was a couple weeks ago, so temperatures outside were like in the teens, 20s, low 30s at night. And then patient also endorses that he feels a little bit off balance when walking. Um, Very brief vitals, physical exam, slightly tachycardic, has like layers and layers of clothes on him. And then the important part, um, you notice the extremities. Both of his feet are cold to touch. They're like whitish, yellowish in appearance, appear to be insensate. And then below the ankles, no palpable pulses, so no DP pulse. Um, Differential diagnosis, there's obviously more, but I just want to talk about like differential diagnosis of cold injuries and how to differentiate them. So the top, we have frostbite and frost nip. These are both like freezing cold injuries. Frostbite's kind of the more severe form and defined as a localized cold-induced injury caused by actual freezing of the tissue. Um, Whereas frost nip is uh, also cold-induced severe vasoconstriction of the skin, but there's no actual ice in the tissue. Important difference is that frost nip resolves after rewarming without permanent tissue damage. And then at the bottom, I just included, uh, just to review, two forms of non-freezing cold injuries. So the bottom left, you have chilblains, which is a localized inflammatory lesions like the ones you see in the picture. It can result from either acute or repetitive exposure to the cold. Important to note that symptoms typically resolve within weeks and that women are more likely to get this than men. And then bottom right, trench foot, another non-freezing cold injury that's from prolonged exposure of the feet to dampness and cold. Um, but can cause tissue loss and long-term sequelae. This involves injury to the sympathetic nerves and vasculature, and it can range from being insensate and numb or being extremely painful. But we're going to talk about mostly frostbite. So acute manifestations of frostbite are going to be on your hands, feet, and then face. So like your ears, nose, cheeks, and chin. Um, Just like with our patient, you'll have cold, the extremity will feel cold, you'll have numbness, clumsiness of the area. Initially will be like hard or waxy to touch, um, and could be like white or grayish yellow before warming. And so how does this even happen? Um, Just going into the pathophys a bit, the quick summary is that you have immediate cold-induced cell death, mixes with the more gradual development of reperfusion-related localized inflammatory processes, all leading to tissue ischemia. So the first mechanism is the formation of extracellular and intracellular ice crystals. This disrupts cellular integrity, causing cellular shrinkage and rupture. Subfreezing temperatures lead to ice crystals extracellularly, and then when you have rapid freezing, you can have ice crystals actually forming within the cells. I just wanted to point out, I know we don't get to this cold here in New York, but starting from negative 30 degrees Fahrenheit, even just exposure less than 1 minute can cause pretty serious injury. And so this can happen quite rapidly. Um, After you have the ice crystals form, you have a couple different processes. First, you have like fluid electrolyte fluxes causing lysis of cell membranes. Then you have an inflammatory process leading to tissue ischemia and necrosis. And then all of the above causes peripheral neurovascular injury, leading to abnormal sympathetic tone and vasospasms. The risk factors, other than being in these freezing temperatures, um, there are quite a few. So for acute factors, exhaustion, dehydration, malnutrition can all predispose people to getting frostbite when they're in these conditions. Any chronic conditions with decreased circulation, so peripheral vascular disease, diabetes, Raynaud's, and then uh, mental illness, so patients with psychiatric conditions um, who may not notice or uh, that a difference in their extremities. With alcohol use disorder, there's kind of that same thought process. And then there's also a thought that you have vasodilation and increased heat loss that further predisposes you to getting frostbite. And the risk is highest at low ambient temperatures with wind chill and higher altitudes. And then I put ice packs on here just because it actually happened in our SICU. One of the attendings had shown me that a patient who was sedated was given ice packs were placed on them for neurogenic fevers, and the ice packs, there weren't like any sheets or anything between them. They weren't doing 20 minutes on, 20 minutes off, and they actually got third degree frostbite from it. So you can have pretty significant injury with ice packs. Um, Prevention, so you want to minimize the predisposing factors that I just listed. Limit exposure to water or metal surfaces. When you're out in the wilderness, maintaining adequate calorie intake and hydration is super important. And then also dressing appropriately to keep yourself dry. So dressing in a way where your inner layers have a like moisture wicking material and the outer layer should be waterproof and have protection against the wind and snow. And then for people who have had frostbite, it's important for them to prevent cold exposure for at least 6 months after a minor frostbite and then 12 months after significant injury. So next, we have our patient with our frozen distal extremities. It's winter. We're pretty concerned that this is frostbite. I'm just going to go through the steps for both pre-hospital and ER management. But the gist is you want to rewarm, um, give pain medicine, thrombolytics if necessary or if indicated, and then general wound care. So first things first, ABCs. So you want to assess for trauma, treat, secure an airway, and then treat hypothermia, reduce or splint any injuries. I like this chart for from the Wilderness Medicine Society on like how to assess for hypothermia if you may not have a thermometer. Um, the summary is like if they're normal mental status, shivering, able to care for self, it's unlikely to be hypothermia and more likely just like cold stress. If the mental status is okay, they're shivering, but they're not able to really care for self, then it's likely mild hypothermia. And if they're altered and shivering, or just altered but still conscious, that's when you want to think about moderate hypothermia. The difference is mainly between the mild and moderate, is that with moderate, you want to be a little more aggressive, you want to place lines, um, if possible, give warm IV fluids in the field, give glucose, completely avoid walking and moving the extremities, and then transfer the patient or send the patient somewhere with ICU level of care. Whereas with mild hypothermia, you don't necessarily need to go to an ICU level of care. Um, More pre-hospital care, you want to prevent further cooling with insulating fabrics, seek shelter, cut off wet clothing, but only once you're within the shelter, and remove like restrictive clothing and jewelry. Um, with mild hypothermia, you can use passive warming, support with calorie replacement, and then moderate to severe, more active rewarming, apply heat to like the torso, chest, axilla, back. You want to avoid rubbing the extremities because that can cause further damage. um, and avoid like stoves fires because the tissue may be insensate and you may burn the tissue if you're not like regulating and careful. And the most important thing with pre-hospital care and rewarming is not to rewarm if the possibility of refreezing before definitive care is there. And so on the next slide, I couldn't really like find anything that really explained it, so I made this a flow chart. Um, but when you have this freezing, warming, refreezing, and rewarming cycle, you essentially just cause more and more tissue damage. And so you have these ice crystals, you warm and have reperfusion with edema, inflammation that's already causing some damage. Now, because you have all this edema and inflammation, if you go back out into the cold, you have refreezing, you have more fluid to freeze into ice crystals. This then damages the stretched edematous tissue and causes increased trauma to already compromised blood vessels, leading to when it does rewarm, you have even worse inflammation and damage. And so you want to avoid that as much as possible. For rewarming, the best way is immersion in water, heated to like 40, 42 degrees Celsius, ideally in a whirlpool, so the steady temperature can be maintained. If there's body parts that can't be immersed, so say like someone's cheeks, you want to use warm, wet towels. Typically want to avoid dry heat because it's harder to regulate. You want to provide analgesia and give gentle active motion of the extremity. Um, Typically takes like 15 to 30 minutes or up to an hour. And once the tissue is thawed, it'll typically be red or purple and soft to touch in comparison to like the whitish yellow, hard, waxy um, tissue that they would present with. With mild frostbite, so like grades 1 and 2, you will see like edema and blisters that occur within hours of rewarming. And then with severe frostbite, it's going to be very minimal to no edema. And so you've put your patient in the Kings County 40 degrees Celsius jacuzzi whirlpool. And here's just some pictures of the results. So the top left, you can see that after rewarming, there's minimal cyanosis, but there is edema and blistering. So this is actually a good sign. It's indicative that it's more mild injury, and it's like grade 1 or 2. The top right, in comparison, you see very minimal edema, cyanosis, no blisters, and that's more grade 3, maybe even grade 4. And then at the bottom, you have some more examples of grade 3 and 4 after rewarming. You have cyanosis down multiple joints with minimal edema and blistering. The blisters that you do see contain blood, and that just indicates that there's deeper injury. And this entire process is painful. So the more the patient regains sensation through warming, the more pain relief they'll need. Ibuprofen has antiprostaglandin effects that work really well. So important to start with that and then add opioids or other adjuncts. Important to also note that the patient should get ibuprofen regardless of the pain for these antiprostaglandin effects, and I put the dosing up. It's recommended like 12 mg per kg per day. It divided it by 2, but that's can be like 1200 milligrams per dose, which is kind of a lot. So could also do like a more normal schedule of like the 800 milligrams or 600 milligrams. For infection prophylaxis, tetanus, not necessary to give prophylactic antibiotics, but it is important for IV or oral antibiotics at the earliest sign of infection. And similar to infected burns, you want like staph, strep, and Pseudomonas coverage. And you want to avoid topical antibiotics because it causes maceration. For any imaging, in general, shouldn't be used if it's going to delay care. But what is recommended are bone scans on day 2 or 3 to predict long-term viability of the affected tissue. This is more likely going to be done already at the burn center that they're transferred to. Um, and then you can use serial CTAs to guide TPA efficacy. Um, Based off from what I read from the Wilderness Medicine Society guidelines, the recommendation is more just to use the serial CTAs if that's what the local hospital guidelines recommend, but it shouldn't overall delay therapy. Which, speaking of TPA, um, with severe injury grade 3 or 4, you have a risk of amputation. And so one thing that you can do is, if it's within 24 hours, is administer TPA. This can be either IV or intra-arterial, and then plus Lovenox or heparin. For intra-arterial TPA, there's not a ton of evidence. The Wilderness Medicine Society recommends if the hospital has the appropriate monitoring setting for it, but just remember you need IR. The theory with intra-arterial TPA is that there's less chance of a systemic bleeding, and so it's like in theory would be better. Contraindications to giving TPA are just like recent stroke, GI bleed, any intracranial trauma. And then every hour delay in TPA is associated with an increased tissue salvage loss of 27-28%. The dosing is typically like a 3 mg bolus followed by an infusion of 1 mg until specialists like your vascular surgeons, your burn specialists say to discontinue, and it's concurrent with heparin. So does it work? There are a lot of like case reports saying published that there is improvement and that TPA may be useful, just like the pictures that I showed here. But in terms of just like reviewing the data and reviewing like systemic reviews, the quality of evidence was determined to be low, despite all these different case reports saying that it's useful. And so based off the like Oxford Center criteria, it's level 3B or 4 evidence. But again, this is because the evidence was mostly case reports or retrospective cohort studies. So in order to truly say that TPA is recommended for this, you need randomized prospective trials or well-controlled cohort studies. But based off of the like case reports we do have, the Wilderness Medicine Society still recommends it if it's within the hospital guidelines. Another medication that can be used with TPA, or if you're out of the TPA window but within 72 hours, or if TPA is just contraindicated, it can be used alone, is iloprost. It's an IV drug. It's a potent vasodilator, a prostacyclin analog. It's actually a pulmonary hypertension drug, but it can be used for IV for severe frostbite, and it's FDA approved for severe frostbite in the US. And it can even be used in pre-hospital settings, but with a much smaller dose. So I think I mentioned before, patients are going to ultimately end up at the burn center that's somewhere that is frostbite experienced, preferably. And the benefit to that is these patients are going to need long-term wound care. They're going to need hydrotherapy to improve range of motion of the tissue. They're going to need special splinting to prevent contractures. They may need repeated tissue debridement, escharotomies, fasciotomies, and possibly delayed amputation. So it's much better that they're at a site, and that if you are administering TPA, that you do it in conjunction with speaking to a burn center that you're going to transfer them to. Q complications of frostbite. And so I already talked about you want to prevent infection because you can have gangrene and infection. You can have necrosis, mummification of the foot. And then I mentioned fasciotomies. With all this reperfusion, edema, and inflammation, you can have acute compartment syndrome. The more long-term complications are like hypersensitivity to cold, scarring, you can have peripheral neuropathy, arthritis, decreased proprioception, hyperhidrosis, and um, it's important to note that the severity of these long-term complication correlates with the severity of the original injury. So back to our original case, our patient kind of had a lot of these more longer term complications already with like the feeling off balance, decreased proprioception. They were actually out of 24 hours. They were out of the time frame for TPA. A CTA was done, which showed arterial flow just basically to the ankles. Our vascular surgery recommended bilateral amputations. The patient declined. They were admitted for grade 3 frostbite management and wound care, and then from the floor were transferred to Jacobi Burn Center. Was treated with aggressive wound care, potential like delayed amputation, but the patient continued to decline amputations, developed infections, which were then treated, and ultimately was transferred back to King's. I'm not quite sure why, but now they're back pending SAR. Um, and then just to recap, it doesn't get too cold in New York, but it gets cold enough, especially if patients are outside all the time or like our patient was sleeping in their car. So it's important to keep cold injuries on our differential in patients with these risks and come in with like extremity pain. Pre-hospital and ER management, the gist is rewarm, pain control, and then thrombolytics if indicated. And then ultimately, the best place for these patients is burn center transfer. And then these are my references.